Hello, everybody. My name is Pierre. I'm from the Rabin Medical Center in Tel Aviv in Israel. And I will be happy to share with you how we can see the personalized nutrition in the ICU. My disclosures. And actually, the main messages of this talk will be to focus on the fact that the needs are different according to the disease or to the gender or the daily variations. That we have a tool called the indirect calorimetry that is today a point of care to guide the medical nutritional therapy. That we may use nitrogen excretion also to guide protein administration, but mainly that we have new technologies that are helping us to administer enteral feeding in a more safe process. Well, we all know the guidelines that have been published by ISICEM, giving us the way to feed the patient properly in the intensive care. However, the intensive care is like a large forest with a lot of patients that are very different, and we may miss the effective therapies. Well, in this forest, we may have patients suffering from obesity, multiple trauma, renal failure, frail patients, septic patients, even COVID patients today, and not all the patients are the same. Well, how we should prescribe energy and protein? We know that predictive equations are inaccurate. We also know that we have indirect calorimetry, which is available to measure energy expenditure. And we also know that high protein intake may be very helpful in specific conditions. We will expand on that. Actually, there were some studies we published 3 years ago in critical care showing actually that if we exceed the 100% of the energy expenditure measured, we may increase the risk of mortality. This was an association which was quite strong and giving a very strong message, telling us that we have to be very careful regarding the administration of energy and not to exceed the 100%. Actually, the best survival was around 70%. So this is focusing on the fact that we should measure energy expenditure. And we submitted recently some paper making a meta-analysis of all the studies that have been used to try to find the efficiency of using indirect calorimetry by targeting the nutrition in intensive care. And you can see here that the 28 mortality was significantly improved when you see the result of the 4 studies that have been integrated in this meta-analysis as far as mortality of the 28 days is concerned. When you look to infectious disease or new infection that is occurring during the ICU, we took here 3 studies that had as a primary outcome infection using indirect calorimetry. And again, we can see that there is also a significant improvement in terms of infection. So there is more and more evidence telling us that indirect calorimetry may help not only to guide nutrition, but also to improve the outcome. The problem is that the fact is variability day by day or according to the disease. And we also published in the paper the day-by-day measurement variabilities, and you can see that the first 48 hours, we have a lower level of energy expenditure that is increasing at day 3, and maybe up and down significantly during the ICU stay. So we may measure more than once patients in the ICU. And the reason is that the fact that sedation, muscle relaxants, pain treatment, but also vasoconstriction and shock and decrease in the function of different organs may decrease energy expenditure. Why? At the contrary, a patient who is more awake, who is in respiratory distress, in a process of weaning or shivering, having seizures, having fever, having organ repair, these patients have an increase in energy expenditure. So a lot of factors are influencing energy expenditure, therefore it would be better to measure frequently. Also, the diseases per se have different levels of energy expenditure. You can see that the burns have the highest level, followed by multiple trauma, but also sepsis is high. diabetes postoperative is also higher than usually found in these patients. And this was telling us that indirect calorimetry may be a point of care testing, actually guiding after measuring the medical nutritional therapy. I will give two examples regarding the diseases. And you can see in trauma that when we looked at our results of patients receiving normal feeding, underfeeding, or overfeeding according to energy expenditure measured by indirect calorimetry, those who had an isocaloric feed with the best survival, the patients with underfeeding had a higher mortality, and the worst were the patients with overfeeding. So it's very important to measure to avoid overfeeding. In the period of COVID, of course, we have to know how to feed these patients, and we issued recently some statements that have been endorsed by a lot of countries in ISICEM, but also by WHO. And these statements are telling us that we should measure energy expenditure if it's possible, and if not, we have to use some equations, but we should feed the patients in the ICU quite quickly using early enteral feeding and to give enough protein. The recommendations are to give hypocaloric nutrition, which is around 70% of the energy expenditure measured within the first 3 days, and then increase progressively. We also issued recently in a paper how to use indirect calorimetry using different practical aspects and trying to decrease the spread of the virus that is also, of course, dangerous. So the target is using indirect calorimetry, but if it's not feasible, use 20 kilocalories per kilo per day, it will be safer. So the first message is using indirect calorimetry to guide the treatment. How about protein? Well, we know that protein is able to be used, or amino acids are able to be used to build protein when you have enough energy. When energy is low, it's a problem. So we need energy, but we need also to know that the patients that are decreasing their muscle mass, these patients have a higher mortality at 3 months or at 6 months. And skeletal muscle density and mass are very important to assess, to evaluate the survival of the patient. But this is also a very important slide showing that there is an association between the amount of protein that you're administrating to the patient and his outcome. And you can see that when you cross the 0.8 or 1 gram per kilo per day of protein, your survival is improving. But be careful, because again, this Amsterdam team is showing exactly the same thing we found in our large observational studies. When you cross the 100% of the measured energy expenditure, your mortality may increase as well. Protein is better. Protein should be given in high dose. However, in septic patients, there is no improvement of the outcome when higher protein intake is administered. So these patients are resistant to higher protein intake. So personalized protein is recommended according to age and frailty. The muscle mass is low. We should give more protein if sepsis is present. There is no reason to give too much because the patient is in an anabolic resistance. Finally, I would like to evocate the preferred early enteral nutrition that has been demonstrated to be very significantly improving outcome of patients in the ICU. And there is a strong recommendation to start early enteral feeding. However, in this audit just recently published, you can see that the early enteral nutrition is not very efficient. Actually, a lot of patients are not reaching the target. Actually, only 0.55 gram per kilo per day is reached for protein. Only 15 kilocalories per kilo per day is reached as calories. So we are far away from the guidelines. And this failure is due to the fact that first, nutrition is not always integrated in the therapy of the patients and has no place in the original SOFA score. And the nutrition aspect is including energy expenditure, of course, the route. And we decided to develop here in our country a new device that is trying to do personalized nutrition-based ICU. And this device has different items. The first is to measure energy expenditure in the respiratory tubing. The second is to introduce a new tube feeding with sensor, which is helping to position the nasogastric tube, but also to help with sensors to detect reflux and to prevent aspiration. We know, actually, that if we are able to measure energy expenditure, this is here in this device derived by the VCO2, we can really decide that we don't want to give more than 70% of these measurements. And we, with this device, also can choose the best formula that is adequate to the requirements and add the protein that is needed. So we will do a personalized nutritional plan. The tube, we will see that it is in position according to the sensors, and then we will be able to start the feeding. The sensors will be able to tell us that there is a minor reflux, and you will be surprised by using this device that you have a large amount of reflux events that are happening during your ICU stay and favorized by the change of position or the bolus administered or the suction made on the patient. And you can see here that we have quite a lot of reflux. Usually, you cannot prevent aspiration. It's very difficult. However, with this new device, with the sensor detecting the reflux, there is an automatic opening of the nasogastric tube to collect the gastric residue. So when this massive reflux is happening, there is also a balloon which is inflated automatically and stopping the reflux to prevent aspiration. Well, we did some studies already on this new device, and we found that, for instance, patients that are on high flow nasal cannula, you can see that there is a huge amount of reflux in comparison to patients who were mechanically ventilated here before extubation and after reintubation. When there is a lot of reflux and sometimes gastric residue, we have a deficit in administration of our enteral feeding. And this is one of the big pitfalls of enteral feeding. But the system is able to integrate this deficit and to create a compensation of a mechanism kicking to achieve the 100 efficiency. Close to recommended calorie and protein intake by enteral nutrition is associated with better clinical outcome of critically ill septic patients, and this device will help to reach this recommended calorie and protein intake. In conclusions, ladies and gentlemen, personalized nutrition is possible. So it's best to target energy using indirect calorimetry. You should also target protein according to clinical requirements. And finally, new technologies could assist the physicians to use enteral feeding more efficiently to reach the target. Thank you, and take it personally.